can anyone tell me in what type of patients do you often find fungal infections?
Immunocompromised
Ma'am,
patients.
immunocompromised.
Yes, immunocompromised patients. That's where we often find the fungal infection. Can you all tell me some antifungal drugs that you have come across?
Amphotericin B,
Yeah,
fluconazole, voriconazole.
yes, yes. Okay. So we discussed about the dilution of amphotericin B. Do you remember? So in which fluid can we dilute the amphotericin B? Can we dilute it in normal saline?
No, ma'am, D5.
It has to be in
D5.
5% dextrose.
5%
Dextrose.
dextrose. Yes. And we also, I told about the electrolyte imbalance. What electrolyte imbalance can you see in amphotericin B treated patients?
Hypokalemia.
Hyperkalemia, yeah. And which amphotericin B preparation is nephrotoxic?
Conventional.
Conventional. Yeah. And most safest is
Liposomal.
liposomal. Yeah. Okay. So now we will move on to the topic. First thing, we will be discussing about Candida infection. What are the risk factors for Candida infection? First is broad spectrum antibiotic usage. Second is central catheters, urinary catheters. So if that is a source of infection, in that case, as a management, we must remove that source of infection. Okay. Next is prosthetic devices and in immunocompromised patients. That includes the patients who have undergone chemotherapy, radiation, who is taking corticosteroids and HIV. Okay. So these are cases. So if the source of infection is any kind of catheter, then that need to be removed. If the patient is immunocompromised, then we have to adjust the dosing or sometimes even stop the drug that leads to immunosuppression. Okay. So it's all a part of the management. So starting with the therapy, coming to oropharyngeal candidiasis, we treat it for 7 to 14 days. Peroral drugs are mostly given for this. Fluconazole is a drug of choice. Alternative is itraconazole, posaconazole. Can anyone tell me about nystatin? Nystatin is not often seen in India. Can anyone tell how to take the nystatin if at all given? Is it to be swallowed or is it to be how do you take nystatin?
Ma'am, I think it is available in powder form.
Okay.
So do we have to dilute it with a given diluent before administration?
Okay. And how do you use it?
Let me check with some and we'll get back.
Yeah, you can. All of you can check and tell me how to counsel a patient who is on nystatin.
Ma'am, is it an oral suspension?
Exactly. Nystatin is an oral suspension. Okay. So someone else tell me, Shiv Sundar, can you tell me how do you take that medicine? You can check and tell me. No problem.
Ma'am, yes, ma'am. Since it is an oral suspension, it has to be shaken well before, administrating each dose, and and switch the medicine in your mouth as, for as long as possible, at least 1 to 2 times before swallowing, and do not eat or drink anything for 30 minutes after usage.
Yes, yes. So you have to swish and swallow the medicine, okay? And nothing to be taken at least up to 30 to 40 minutes after taking the medicine, okay? That's how you should counsel the patient. Yeah, and can anyone tell me, Feba Mary, have you heard about candid mouth paint?
Yes, ma'am.
Yeah, can you tell me how to counsel the patient when the patient is on candid mouth pain, how to use it?
Yeah, that is
You
like
can check and tell also, no problem. You can check and tell.
ma'am.
Yeah, tell me.
So it's like, first of all, we have to shake the bottle well, and then we have to measure the prescribed dose using a dropper
Okay.
and place the
Okay.
suspension in the mouth, then swish it all around the areas of the mouth.
Yeah.
And then we should not immediately swallow the medicine and should keep in contact with the affected area. And the suspension can be swallowed after swishing for after some time.
Yeah. Okay. So now we understood, no? So anything for Canada, both candid mouth pain, statin, the method of administration is similar. Okay. Now, coming to esophagus. So remember, oropharyngeal candidiasis, drug of choice is an azole. Fluconazole is what we most commonly use. The alternatives are rest. Okay. And you have to treat for 7 to 14 days. Coming to esophageal candidiasis, you have to treat for 14 to 21 days. You can go for fluconazole, peroral or IV or itraconazole peroral. Alternatives are other azoles, caspofungin, micafungin and all, amphotericin. So these are for severe infections. Otherwise, we will go for only fluconazole or itraconazole. Okay. Coming to vulvovaginal candidiasis, fluconazole, a single dose can be given as orally or a topical azole for 3 to 7 days. Okay. So sometimes you can see consultants using a combination of these two. That is not required. Either an oral dose of fluconazole, a single dose, or a topical is enough. Now, alternative option is itraconazole, and the treatment duration, if you are going for topical, is 3 to 7 days. Okay. Now, candidemia, how do you manage is that we have, while if a patient is diagnosed with candidemia, we have to repeat the culture until the patient is culture negative, and after the culture negative, first culture negative we get, no, then we have to continue the treatment for 14 days from then. Okay, so that's how the treatment happens. Okay, we should not stop the treatment when the culture negative we get. After that also we have to continue up to 14 days. So candidemia, echinocandins are the drug of choice. Caspofungin, anidulafungin, remember that. Okay, so candidiasis, oropharyngeal, esopharyngeal, we saw that azoles are the drug of choice. Whereas coming to candidemia, echinocandins are the drug of choice. Fluconazole can be given only if the organism is sensitive to the fluconazole, and amphotericin B is recommended, that to lipid formulation, for resistance or intolerance to other antifungals. So you will come across cases wherein candidemia doctor would be going ahead with the amphotericin B as a first choice. That is not right. Okay, echinocandins are the first choice in candidemia. Then as per the culture report, you can manage the case. Fluconazole is used only if it is sensitive, and amphotericin B is used only if the culture shows resistance or other antifungals are intolerant to the patient. Okay. Now coming to endocarditis, there amphotericin B lipid formulation is the first line agent, along with or without flucytosine or high dose echinocandin. So endocarditis, we have to go for combination therapy, not, or you can give single agent also, but if you're combining, you have to combine with the flucytosine or a high dose of echinocandins. Okay, amphotericin B with or without flucytosine or high dose of echinocandins. Fluconazole, voriconazole, or posaconazole you can use as a step-down therapy. Once a patient has become stable, then you can do as a step-down therapy only if culture shows that it is azole sensitive. If the culture shows that it is sensitive to any of this agent, then only you go for this azoles antifungal. Okay, so if the patient has had a valve, okay, endocarditis and are usually seen in patients who are having prosthetic valve. Now we have removed the prosthetic valve. In that case, and a new valve is placed. In that case, we need to continue the treatment for 6 weeks. Okay, but if a patient in whom we have not undergone the surgery, we have not done the surgery, the valve was not replaced, in that case, you have to go for chronic suppressive therapy. Okay, with the fluconazole. Okay, chronic long-term suppressive therapy has to be given for this patient with the fluconazole. So, in coming to endocarditis, amphotericin B with the flucytosine or high dose echinocandins, fluconazole or any azoles only if sensitive to that and antifungal. If the valve has been replaced, you can treat for 6 weeks and stop the therapy. If the valve has not been replaced, chronic suppression with fluconazole has to be done. Coming to osteomyelitis and septic arthritis, drug of choice is fluconazole. But the duration of treatment is 6 to 12 months. Almost an year we have to give the medicine. Okay. Second choice is echinocandins we can give for first 2 weeks. Then you can go for fluconazole for 6 to 12 months. Other option is amphotericin B for 2 weeks followed by fluconazole for 6 to 12 months. Septic arthritis, the same drug we give, but the total duration of therapy is 6 weeks. Understood? So osteomyelitis, 6 to 12 months is the duration of the treatment. We can either give fluconazole for 6 to 12 months, or we can initially start with echinocandins or amphotericin B for 2 weeks, then move to fluconazole. Or if the patient is septic arthritis, the total duration of treatment is 6 weeks, not 6 to 12 months. Now, if the urinary tract infection, if the patient is having an indwelling catheter or nephrostomy, any tube, any stent, that need to be removed first. The source of infection need to be removed first. Now, if the patient is asymptomatic, okay, there is no symptom, but the culture has shown a fungal growth. In that case, do not treat, okay, do not treat unless the patient is neutropenic or undergoing a urological procedure. Can anyone tell me what is neutropenia, Vasanta?
Ma'am, I will check and tell you.
Yeah, please check and tell me what is neutropenia. Vasanta, can you tell me what is neutropenia?
Reduction in neutrophil count.
Reduction in?
Neutrophil counts.
Neutrophil count. Okay. So asymptomatic bacteriuria or fungal growth need to be treated only if the patient is having undergoing a urological procedure or the patient is neutropenic. Then when it comes to asymptomatic bacteriuria, if there is a bacterial culture growth in urine and the patient is asymptomatic, if the patient is pregnant, then also you have to treat. Otherwise, do not treat asymptomatic bacteriuria. Okay, coming to symptomatic bacteriuria, fluconazole is a drug of choice. Give for 2 weeks. Next is, in this case, we can go for amphotericin B instead of liposomal preparation for 7 days or flucytosine for fluconazole resistant case. Okay. Okay. Now, other azoles. Here you have to see fluconazole is the only azole that is recommended when it comes to urinary tract infections. other azoles and echinocandins does not achieve any urinary concentration. For UTI to be treated in the urine, in the bladder, enough concentration need to be achieved. Okay, so other azoles or echinocandins does not achieve that. Therefore, we cannot give them. So here only option is fluconazole or amphotericin B, and here we can go for non-liposomal preparations. Duration of treatment is, if you're going for 2 weeks, fluconazole, or if it is flucytosine, 7 to 10 days. If the fluconazole resistant case, then only you need to go for amphotericin B or flucytosine. Otherwise, do not use that. Okay. Okay, so when it comes to urinary tract infection, if the fluconazole resistant the organism is there, then what are the options that we have for treating? Can Shahanas tell me?
And we have
If
amphotericin B, which is not liposomal preparation.
And or either flucytosine. Yeah. Okay, now coming to invasive candidiasis that we often see in the ICU, empirical therapy. So when do you start empirical therapy? If the patient is having unexplained fever and risk factors, what risk factors? Candida colonization is possible. Okay, if there is a catheter or anything is there, in that case, Candida colonization is possible. Okay, severe illness, patient is severely sick, patient has history of broad spectrum antibiotic use, patient has undergone a recent abdominal surgery, if the patient is having an necrotizing pancreatitis, dialysis patient, total parenteral nutrients are being given to the patient, if the patient is taking corticosteroids and central venous catheter is there. So all these patients are at risk of invasive candidiasis. So if the patient is having all the unexplained, we have given all the antivirals has been tried, yet the patient is still having fever. So we have to consider antifungal if the patient have any of this risk factor. Okay. So in this case, echinocandins are the recommended choice. Fluconazole can only be used when if the patient does not have any recent history of azole use or colonization history with azole resistant organism. So fluconazole should only be used if the patient has no recent history of azole antifungal use, or patient does not have any history of any colonization with azole resistant organism. Amphotericin B lipid formulation if the patient is resistant to other antifungals or intolerant to other antifungals. Duration of treatment is 2 weeks. If the patient responds, you can continue for 2 weeks. If the patient has not responded after therapy, you can give it for 4 to 5 days and then stop it. Okay, then it is not a fungal infection most probably. Okay. So if the patient has responded, continue for 2 weeks. If the patient has not responded, take it for 4 to 5 days and then stop it. Okay, that's how we manage in empirical therapy. Now, prophylaxis. If